spinal shock, that means the spine stops functioning for a certain time, then gradually it starts functioning again. And if you do any investigation about the spinal cord, everything will be normal. But due to the impact or trauma, they stop functioning for a little bit of time. That is spinal shock. And usually, and we now know that in hypovolemic shock, due to the blood loss, usually spine fracture might be associated with long bone fracture, pelvic fracture, and a lot of hemorrhage might be there. Hypovolemic shock is there. Then you have now known that the neurogenic shock due to the nerve injury, it could be neurogenic shock, bradycardia with hypotension, and another is spinal shock. And the spinal shock usually transient loss of spinal cord function, and many times this recovers in 24 to 48 hours of time, and sometimes it might take few days also. So when a patient with a spine injury comes to you the first time with unable to move his upper limb and lower limb, you shouldn't be saying that this is the final nerve injury that the patient is having. The patient might be still in spinal shock. When he recovers from spinal shock, usually the neurological deterioration or neurological dysfunction will come back. And how you will know that the patient is in spinal shock or is having real cord or nerve injury? For that, there is a loss of bulbocavernous reflex and anal weak in spinal shock. When patient is in spinal shock, we have to examine for bulbocavernous reflex and anal weak. These will be absent. And if a patient is there with the spine injury, who doesn't have bulbocavernous reflex or anal weak, you should wait. The neurological system might recover. And if there is bulbocavernous reflex and anal weak present, that means patient has recovered from spinal shock. Okay, then we have two different type of, and how you know about this bulbocavernous reflex and anal weak. In bulbocavernous, the patient is usually catheterized. If you pull the catheter or if you squeeze or give a pressure in the urethra, or if you give any pressure, male or female, if you give any pressure, pull out the catheter, easy thing will be the pulling out the catheter, then anal tone contracts, anus contracts, that is bulbocavernous reflex. And anal weak also the same. If you pick perianal region with a sharp or pin or whatever, anus contracts, then that is known as anal weak. And if you have found that there is a bulbocavernous reflex and an anal weak present, that means you have to understand that patient has recovered from spinal shock. And regarding the treatment, as we all know that there are two methods of treatment: conservative treatment and operative treatment. Conservative treatment is with bed rest. We don't operate on them. In operative treatment, there are different modalities of treatment. Indications for operative treatment: when we conservative treatment, what is it? We give rest to the patient. That is for stable fractures. We give rest for some days. If there is a burst or compression fracture, a lot of compression is there. But if not, neurological system is intact, if there's no big fragments in the spinal canal, then if you keep the patient for about 6 weeks of bed rest, fracture heals. And when patient starts moving, starting up and moving or starts walking, the spine will be stable. There will not be further deformation or distortion of the spine, and the spinal cord will not be damaged. These are stable fractures, and conservative treatment can be done with those patients. And another is operative treatment. And operative treatment, we operate. And what are the indications for operative treatment? Number one is unstable fracture with progressive neurological deficit. Another is unstable fracture in a patient with multiple injuries. If there is upper limb injury, lower limb injury, spine fracture, if these patient with the polytrauma should be fixed properly. And because taking care of the other fracture is difficult without fixing the spine. Because for limb fracture, you have to wheelchair mobilize, you have to let patient walk in the crutches, and the early mobilization will be very easier if you fix up the spine in polytrauma patient. So, an unstable fracture in patient with a multiple injury or unstable fracture with neurologic deficit, these are the absolute indication for the operation. And another relative indication, incomplete cord injury. If there is partial neurological deficit, that is a indication you have to operate, because you have to make this cord free. Unstable fracture with neurological deficit. And another is kyphosis more than 30 degree. If there is compression fracture and if the kyphotic angle, kyphosis of the spine is more than 30 degree, if there's compression more than 30 degree, you have to operate. And with what is the advantage of the operation is early rehabilitation and prevents further kyphosis. If you leave 30 degree of kyphosis and later on when patient gradually walks, he starts doing heavy works, then gradually spine deformity increases. So to prevent further kyphosis and prevention of later back pain, if the spine alignment is not maintained, if there is deformity, gradually later life patient will have some back pain. So if you see this picture, there's a fracture and this is a spinal cord. Cord has been freed. This posterior part, the spinous process was removed. Lamina was removed, and we gave a little more space for the cord to expand. And this is it after the surgery. Cord expands. These are the rod and screws that is kept. If you see this fracture here, now the fracture vertebra shape is maintained, and these are the screws and rod system, and decompression was maintained there. Decompression, you can see whole lot of space, empty space here. That means spinal cord is decompressed in this area. This is the fixation of the pedicle screws. The screw is going from pedicle to the body. We call it as a pedicle screw system. Pedicle screws and rod fixation, posterior instrumentation. This is and conservative management. How we do conservative management? Conservative management starts from the transportation of the patient. A, B, C. Proper immobilization should be done in A itself. Proper immobilization, log rolling. If you have to see the patient, if you have to do the inspection of the back, then patient should be turned as a single load, log loading 1, 2, 3, then turned as a single piece. Then from posterior part, you have to examine the patient. And for cervical spine, for stable fracture, hard collar can be kept. For unstable fracture, skull traction, this traction can be kept for some time till bone heals over here. And after bone healing, the traction should be removed and patient can be mobilized. For thoracic, lumbar, and sacral spine, for stable fracture, conservative management, we do complete bed rest for 6 weeks, because it takes 6 weeks to heal the bone. That's why give patient complete bed rest for 6 weeks. Then after that, with the help of braces and support, you mobilize patient. And what are the other cares we must do? It's the skin care. And think that if you keep a patient for 6 weeks in one position, what happens? Skin will be destroyed. Bed sore occurs. So the main thing is to prevent from the bed sore, formation of the bed sore, especially if neurological deficit patient, paraplegic patient, they won't be able to move by themselves. And you have to our main job, first job will be to prevent the patient from getting bed sores. And for that, what should be done? No creases and crumbs in the bed sheet. Bed sheets will be very tightly, snugly fitted over in four corners. There shouldn't be creases in between. This crease will make a crease, and the crease of the bed will make a crease at the skin, and the skin, there will be bed sores. And 2 hourly turning of the patient should be turned to right or left supine. In 2 hour turning should be there, otherwise bed sore starts coming up. Back is washed without rubbing. You shouldn't rub the back, because this should be just gently washed, gently toweled. This should be dried with a towel. Don't do any rubbing, because skins are very thin there, and bed sore can occur easily. Dried and powder, always the back should be dried. If there is sweat over there, or if there moisture over there, the skin will be little, then the sloughing or of the skin, and skin gradually bed sore occurs in those area. Then if bed sore develops, then what to do? The excision and grafting of the bed sores. Bed sore, if there are small bed sores, if you eliminate the pressure on that area, gradually it heals. But if there are big bed sores, then bed sores should be excised, and regular dressing should be done. And sometimes you need the plastic surgery help, or the grafting of the muscles and skins might be needed in those areas. And then bladder care, number one. Then usually in cauda equina patient or paraplegic patient, bladder and bowel is involved. So bladder care should be there. Catheterization continues. So initially for a few days you do continuous catheterization. Then after that, the clamping of the catheterization will be there. If you keep the catheterization continuously for days, bladder shrinks. Then later on, the bladder will not be functioning as a bladder itself. It will not act on it, will be contracted. So to prevent the contraction of the bladder, if you have put the catheter, you clamp the catheter, and intermittent release of the catheter should be done. And later on, the catheter shouldn't be kept permanently. If a patient doesn't recover from neurological deficit, if he has got continuous bladder problem, then intermittent catheterization should be taught to the patient or patient party to evacuate the urine from there. And another is bladder care. Always there is a problem with the constipations. Then manual evacuation of the stool should be done. Give some laxative enema, and abdominal exercise should be done. These patients are bedridden. They are very less mobilized. So the immobilization occurs, constipation. So even lower limbs are not moving. Abdominal exercises, pressing the abdomen by patient itself or by other people will move bowels, and little bit of peristalsis occurs at the bowel, and the softening of the stool and defecation would be little easier. So abdominal exercises should be done. And rehabilitation of the paraplegic. If there is paraplegic, both the lower limbs are not functioning, should be done by a team of people. There should be doctors who are taking care of the spine fracture, physiotherapists teaching a lot of exercises, and the nurses to take care of them, occupational therapists. Once patient is a paraplegic, he won't be able to move around by himself. He should be earning his bread and butter by himself. That's why he should be taught to do some work manually with his hands, intact hands. And this can be done with occupational therapists and social workers. That's why this is a teamwork. If there is a paraplegic patient, there should be teamwork involving in the treatment. And another important thing for the treatment of paraplegic patient is to prevent from severe flexor contracture. Paraplegic patient, if there is a spinal cord injury, there will be spasticity. Patient might be having flexor contractures. So the passive stretching of the muscles and exercises should be done, and to prevent from. Then another is to prevent from bed sores, or even if you mobilize the patient in wheelchair, there could be sores by wheelchair. That's why there should be hard part touching to his body while he is mobilized in wheelchair. and another to develop sufficient power in both upper limb, lower limb. If the lower limbs, both lower limbs are not functioning, upper limb, power of the upper limb increases, and he should be learning the skills to do all the things by upper limb, and they should be taught about it. And another is to enable the patient to use crutches and wheelchairs everywhere, even the climbing the stairs also. Some people use the crutches and braces, and even the climbing up and down wheelchair, special modified wheelchairs are there, and patient should be trained to do that. Even patient can be, if you go around, sometimes you can see the scooty with extra wheels around it. The paraplegic people use it. They put their crosses over there, and these are the training you should. And the occupational therapy, physiotherapist will teach how to transfer himself from the crosses to scooty or to the car. In other developed countries, there are special cars for paraplegic patient and wheelchair. This is transportation of the patient from crutches or wheelchair to the car and to the scooty should be taught carefully. And when you go around in Kathmandu, sometimes you see scooty with all the extra wheels and with the paraplegic patient driving it. So, and active physiotherapy is very much required. Calipers, braces are very much important to stabilize lower limbs. And if rehabilitation center is available after the primary treatment of the patient, he should be sent to the rehabilitation. In our country, we have couples of rehabilitation center. In Sangha, there is very good spinal cord rehabilitation center. If you send the patient there, they will teach everything, taking care of themselves, then wheelchair mobilization, transportation of the patient, and even they teach a lot of skills. They can they teach patient to do a lot of works by their hand to earn for bread and butter. This is done in rehabilitation centers in Pokhara, in Dharan. There are a lot of places. There are government or NGO type of semi-government rehabilitation center. We used to send those patients there, and they will take care of them. And if patient develops severe deformity, contracture, or would develop myopathy, then if the lower limbs are spastic, then tenotomies, the tight tendons can be released, or a neurectomy, the nerve that is innervating their neurectomy is done, then the spasticity will be resolved. The rhizotomies are intrathecal injection of alcohol, or the alcohol is usually given, or ether also is given in those areas to desensitize nerve to reduce the spasticity. Can be done this. And main treatment goal is rest in neuropraxia, contusion, little bit of hematoma is there, concussion, little bit swelling is there, neuropraxia, it's a transient loss of function of the nerve. Rest, give just rest, it will recover. Decompression in spinal cord compression, if there is cord injury due to compression by the bone, big fragment of the bone, you have to remove that fragment, you have to decompress it to let the cord work or function properly. If there's cord transection, cannot be repaired. If there is complete cord, don't try to repair it, because still now there is no mechanism or no facility or no proven document that if you suture the cord, it will start functioning. It doesn't function. That's why transected cord cannot be repaired. And rehabilitation of the paraplegic patient, rehabilitation is one of the very important part in the treatment of spinal cord injury or the spine injuries. Okay, thank you. This was for today. Any question? Do you have any questions there?